ICU medicine, academically senior lecturer at the medical faculty of the University of Lausanne and Lugano, founding member and deputy president of the Swiss Latin Airway Foundation FLAVA, internationally renowned expert in the field of difficult airway management, main author of the Swiss Latin Airway Management Guideline, recently adopted by the Swiss Society of Anesthesia and Perioperative Medicine, inventor and medical developer of an innovative virtual reality simulator for teaching flexible bronchoscopy, the computer airway simulation system. Dr. Casso, the word is yours.
To the organizing committee for the invitation. I apologize for not being physically with you today, but the tense situation in the Middle East has unfortunately forbidden it. In the next 20 minutes, I will present to you a new holistic approach for difficult airway management that we have developed in Switzerland. First of all, I quickly introduce myself. My name is Gabriele Casso. I'm the deputy head of the Department of Cardiothoracic Anesthesia and Intensive Care in Lugano, in the Italian-speaking part of Switzerland. I have an academic activity at the universities of Lugano and Lausanne, and I'm the deputy president of the Swiss Latin Airway Foundation, the FLAVA Foundation. I don't have any financial conflict of interest to declare for this lecture. FLAVA is a Swiss non-profit foundation created almost 15 years ago to promote safe airway management. The French and Italian-speaking part of Switzerland are represented in the board, in particular the University Hospital of Lausanne and Geneva. FLAVA is supported by the Swiss Society of Anesthesiology and Perioperative Medicine, and our difficult airway courses are endorsed by European Airway Management Society and the Difficult Airway Society. So to start, what are the problems? Why do we need airway algorithms or guidelines? We all know that airway management complications remain a leading cause of anesthesia-related morbidity and mortality. An inappropriate clinical practice and inadequate management contribute to airway management difficulties. A lack of organization, strategy, equipment, and judgment are the main contributor factors of airway management complication. Therefore, we definitely need airway guidelines to improve our clinical practice. On this very busy slide, we have different examples of international algorithms, and we can see that they are all different in their content and graphic design. Here is a summary of the various international guidelines that are regularly updated. The latest to be published are the third edition of the Canadian guidelines in 2021 and the fourth edition of the American ones last year. As you can notice, there are so far no Swiss guidelines. That's why in 2013, within the framework of FLAVA, we decided to develop common guidelines for the Latin Switzerland. It is our first FLAVA algorithm, inspired from the Difficult Airway Society algorithm of 2004, linear, with a sequence of steps, A, B, C, D. We were the first to introduce a color code to highlight time pressure in airway management, and we had a great success. Our algorithm was quickly adopted by most of Swiss Latin institutions. In 2015, the Difficult Airway Society guidelines were updated, taking into account lessons learned from the NAP4 audit. They introduced new technical skills, as for example, video laryngoscopy and second-generation extraglottic devices. They also integrated some non-technical skills, for example, declare failure of a plan, stop and think in case of difficulty. But as you can see, they kept the same linear setting. But in fact, as you know, airway management is not always linear. As nicely highlighted by Nicholas Crimes from Australia in his brilliant vortex cognitive tool, airway management in real life is not linear, but open and dynamic. The blue funnel representation of airway management shows the decrease in time available at each failed attempt and the risk of hypoxia. The vortex approach also shows the extreme importance of safety and non-technical skill, as for example, teamwork and strategy. The can't intubate, can't oxygenate situation is for me the best example of the importance of this kind of graphic cognitive tool. In this situation, you have to prepare the rescue cryothroidotomy before you get to the bottom of the blue funnel. If you start your technical and mental preparation to perform a rescue cryothroidotomy too late, your patient will be already dead. That means that early priming the can't intubate, can't oxygenate rescue is essential. All these important new inputs were taken into account, and last year our scientific committee updated our guidelines. I will present them to you in detail in the next 15 minutes. If you scan the QR code on the top right of the slide, you can download our full article for free. As you can see, our guidelines include circular cognitive tools, a linear algorithm, and also important acronyms. Let's start with the colored circular cognitive tool for technical skills. We have different techniques for colored plans. The green plan, direct intubation using a Macintosh blade. The yellow plan, indirect video-assisted intubation. The orange plan, ventilation. And the red plan, rescue front of the neck oxygenation. The good combination of this plan makes it possible to develop a personalized strategy customized to the patient, the team present, and the clinical situation. The green plan is direct intubation using a Macintosh blade. It still remains the gold standard in most anesthesia departments. With a traditional Macintosh laryngoscope, you have an angle of view of about 50 degrees. If you use a Macintosh blade video laryngoscope, you can improve the angle of view on your screen up to 40-60 degrees. The use of a Macintosh video laryngoscope significantly improves the success rate of intubation. In this very recent study published on anesthesia this year, it was found a 12% increase in intubation success on the first attempt in adult elective patients in OR without predicted difficult airway. We have the same result in ICU, an increase of plus 13% of successful intubation the first attempt in this study published 3 months ago in the New England Journal of Medicine. But pay attention, video laryngoscopy doesn't work in any situation. The use of a Macintosh blade on direct view still remains the best solution in some specific situations, as for example, massive bleeding or secretion that can soil the camera and don't allow you to see anything anymore on your screen. This may happen with trauma patients, for example, as you can unfortunately find during the current difficult war situation in Middle East. However, nowadays we have scientifically solidly proven evidence of the superiority of video laryngoscopy over direct laryngoscopy. In this huge meta-analysis published last year on BGA, we see that video laryngoscopes reduce failed intubation and improve glottic views. Furthermore, video laryngoscopes with hyperangulated blades reduce esophageal intubation and improve successful intubation in patients with difficult airway. In case of anticipated or non-anticipated airway difficulties, we suggest therefore the yellow plan. The yellow plan is indirect video-assisted intubation using a hyperangulated video laryngoscope, channeled or not channeled, or a flexible endoscope. In few very difficult cases, we may need to combine both techniques, video laryngoscopy and flexible endoscopy. This is a 2 operators 4 hands technique. The orange plane is for ensuring ventilation and oxygenation through facial mask or second-generation extraglottic device insertion. We have chosen second-generation extraglottic devices to increase safety in case of regurgitation through the gastric drainage lumen, or an improved seal when needing a higher airway pressure. And last but not least, the RED plan, front of the neck rescue oxygenation. We graphically added a reminder of the importance of early preparation of the RED plan as in vortex approach. The red circle surrounding the 4 plants becomes progressively more intense in color as it approaches the RED plan, highlighting the importance of early priming for emergency front of the neck access, as difficulties intubating and oxygenating the patient increase. In most of the cases, we will prefer the surgical approach, scalpel finger bougie tube, but if the cricothyroid membrane is well identified by easy palpation or previous cervical ultrasound assessment, then a needle approach may be considered as well. Why a circular cognitive tool? But to remind the right combination of the plants is not always green to red. The clinical situation and the team expertise will dictate the best combination. I will give you now some clinical examples to explain this concept. If you have a non-expected difficult direct laryngoscopy with a patient with a core MacLean grade 3 or 4, you will choose to switch to an hyperangulated video laryngoscopy. So you will go from the green plan to the yellow plan. If you have the same situation, but suddenly the patient desaturate, you will skip the video laryngoscopy and go directly to the orange plan to ensure oxygenation by face mask or laryngeal mask. So you will go from the green plan directly to the orange plan. If you had a patient with anticipated difficult airway, where you decided to start with video laryngoscopy with an hyperangulated blade as first choice, and suddenly it was impossible to visualize vocal cords because continuous massive bleeding or a lot of secretion, in this case, perhaps you will decide to go back to direct laryngoscopy using a large bore aspiration and suction to intubate this patient. So you will, in this case, go from the yellow plan to green plan. Or another clinical situation may be a general anesthesia with a laryngeal mask as a first line, and then suddenly a failure of laryngeal mask insertion due to air leaks. So you decide an intubation by direct laryngoscopy, but the patient is difficult to intubate, and you switch to a video laryngoscope with an hyperangulated blade to intubate successfully your patient. In this case, the sequence of plan will be orange to green and back to yellow. You can even start directly from an initial front of the neck access, a patient with a severe angioedema, making access through the mouth or the nose impossible. In this case, you make an emergency cricothyrotomy under local anesthesia. So the circular design helps to understand the need of a personalized, adapted strategy in any situation. Of course, in some specific situation, as for example, a non-expected difficult intubation during the night at 2 a.m. as a young trainee, you need to have a clear linear algorithm in your head. In this case, you only need to enroll the circular cognitive aid to get it, and you will find a linear algorithm for unexpected difficult intubation. We also created 2 important acronyms that we voluntarily placed in the middle of the cognitive tool because they are important in every situation. The first acronym is OPTIM. OPTIM reminds during the wall takeover the importance of optimizing procedures. O2, oxygenation. Periprocedural oxygenation to prolong apneic time should be a priority. Various techniques may be considered. If you need PEEP, as for example in ICU patient, you can use non-invasive ventilation to pre-oxygenate your patient. Periprocedural nasal high-flow humidified oxygen up to 70 liters per minute may also effectively prolong your apneic time and increase patient safety. P, positioning, burp, suction. T, different types and size of tools. For example, different kinds and size of LMAs. I, introducer, very important in case of hyperangulated video laryngoscopy. M, muscular relaxant. Sometimes you should give them, for example, to facilitate mask ventilation. And in some situations, you want to quick remove them as well. M, cricothyroid membrane identification. In case of anticipated difficult airway, a routine echographic identification of cricothyroid membrane before anesthesia induction may speed up and improve a potential rescue front of the neck access. And very important, in this holistic approach, the FLAVA color-coded airway trolley. The organization of the difficult airway trolley and its tools must reflect the algorithm using dedicated colored plans, green, yellow, orange, red. Each drawer corresponds to a plan, is color-coded according to each plan, contains the tool to achieve the plan, and the algorithm must be easily accessible and clearly visible. Here are some examples of FLAVA airway cars. On the left side, the trolley of my institution. On the right, the cart of the University Hospital of Lausanne. We also created ad hoc stickers with the colored logos of the technical skills. The stencil to print them out are available for free download on our internet site. These stickers will allow you to transform an already existing trolley into an affordable FLAVA airway trolley. We move now to the non-technical skills and our second acronym, SOS. Easy to understand. If you have a problem, you call SOS. SOS want to promote in-action team reflexivity in case of non-anticipated airway difficulties. SOS means to slow down and invest time for reflection, trying to avoid the tunnel effect. S, stop, state the problem, describe the situation, and allocate time to reflect. O, options, invite input, analyze, understand the causes, and decide on next step accordingly. And S, share, communicate, and allocate tasks inside your team. The blue circular cognitive aid for non-technical skills contains the 3 key moments of reflection in patient care. The preoperative briefing dedicated to preparation and strategy to reach a shared understanding. We have already spoken about inaction SOS, and at the end of a difficult takeover, a debriefing is essential to learn and to try to avoid the same mismanagements in the future. Using the briefing, you will be always ready. With the SOS, you will be always adapted. And with the debriefing, always better. Summarizing, the key for success in airway management is the combined use of technical skills and non-technical skills. This year, the FLAVA airway guidelines have been endorsed by the guidelines. Switzerland is multilingual. So we have translated the English version into the other national languages.
Hi, doctors, how are you? Doctors will be taking the Q&A now. We still have 1 minute for the recording to end, okay? You will hear questions from the audience, okay? Whenever you hear the question, you'll be on live. You can start directly, okay?
Interest you in Lebanon. Should it be the case, do not hesitate to download and use whatever you need of our guidelines.